Hello, hello, welcome. Today we're talking all things TMJ, TMD. You know what really grinds my gears, guys? And this is like a really random thing, but when people are like, oh, I have TMJ, I'm like, everybody has TMJ. Like, we all have a temporomandibular joint. We're going to talk about the joint, and we're also going to talk about dysfunction of the joint and how all of that like comes together. And with myofunctional therapy as the focus. So today I'm super excited because I'm going to actually try to see if I can get PowerPoint to work on here. So we're going to try and see if this is working really smooth and seamlessly. Welcome, 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 welcome. I'm so happy to have all of you in here tonight. This actually has brought in a lot of attention, and I'm really not sure why. I guess TMD is something that everybody wants to know more of. Let me know that you can hear me, that you can see me. Give me a nice hi in the comments, in the chat. Just let me know it's safe to keep going and to dive in, because I'd hate to have to start over because something's going on with my audio or whatever. So if I sound, like if it's breaking up, if the sound's not looking good, like please, somebody stop me at some point, sometime. All right. Okay. So now that we've got our welcomes in, let's dive in. Let's dive in. All right. So temporomandibular joint disorder or dysfunction, we know, affects a large portion of the population, at least 1/3. So 1 in every 3 people that you talk to has at least one temporomandibular joint disorder symptom, and 3 to 7% of the population with that dysfunction has severe enough severity that causes them to seek treatment. So out of 33% of people, and we're like a global population of nearly 8 billion, a third of that has problems, and a small fraction, less than 10% of that, will actually go and seek out treatment. So what you really know is that a lot of your people aren't coming to you with this issue. Although we do know that in dentistry, we're really good at hearing it, seeing it, defining the crepitus, the popping, the clicking, the dysfunction, and so forth. So a lot of it is muscular. Some of it is structural. What is that word? Is structural. And there is a good portion of it that is, related and associated with occlusion. Okay. So we're going to kind of touch on all of those and how everything kind of comes together, and where everything for OMT comes together. And you can't get there unless you understand that where your tongue rests matters. So I used to say, and I need to really put this slide in more, but I used to say that in every presentation, I find somewhere to put this slide, even if it has nothing to do with myofunctional therapy. And I've been speaking a lot more about things that do have nothing to do with myofunctional therapy, but where your tongue rests matters for a number of things: for mental health, for your sleep, for your craniofacial growth and development, for the stability of your orthodontic treatment. Where your tongue rests matters for just about every gosh darn thing in the world. And people aren't talking enough about it. That is my, my soapbox. That's my soapbox. That's what they call that. That's my soapbox. So we want the tongue at rest to be lightly suctioned against the palate from the incisive papilla. All of my dental people, if you're not a dental person and you're on this, hey, happy to see you. Just beyond your upper front teeth, all the way back through to the soft palate, and you want to have it lightly suctioned. So you want to feel all of that against the body of your tongue. So you should be able to feel the front, the middle, and as posterior back as you can, the tongue against this palate. If it's not there, something's going awry. Like something in some way, shape, or form is going awry. If it's halfway there, if it's kind of floating in the middle, how do you know where your tongue is resting? Great question. You know where your tongue is resting by planting your feet flat on the ground. If you are seated, if you're standing, stand. If you're driving, please pay attention to the road. If you are seated, feet flat on the ground. If you're standing, just stand and try to be very mindful of your posture. Now, with your feet flat on the ground, I want you to take a deep nasal inhale. So inhale through your nose. And then I know you're tempted, but don't. I want you to exhale through your nose and not your mouth. Okay. We're going to repeat that. I want you to repeat that 3 times. Inhale through your nose, exhale through your nose, and keep going. Now, as you're doing this, I want you to just become very attuned. If you are able to, you can close your eyes and just kind of zoom in. What's going on? Are my teeth together? Is my tongue where it's supposed to be? How do my lips feel? And I want you to really just start to come back from that breathing with that new awareness. And I want you to now just be mindful of where everything was. We want the teeth to be slightly apart. So if you felt your teeth together, you're probably here for a reason that has less to do with your patients and more to do about your own temporomandibular joint dysfunction. But it's a part that we want them to be about 2 to 3 millimeters of freeway space in between the arches. So our teeth are really only supposed to be together when we're in occlusion for mastication. Outside of that, probably never. They should be together. And if you're finding that they are together, don't worry. Myofunctional therapy is really great for that. If your tongue is kind of floating in the middle of your mouth, if it's all the way down on the bottom, if it's only partially up and not all the way up, that's fine. Don't worry. Myofunctional therapy can help you with that. This slide is really just to say that when there is dysfunction with where the tongue is resting, when there's dysfunction in oral rest posture in any way, shape, or form, when there's mouth breathing, it's going to impact the function of the temporomandibular joint. It is a contributing factor to temporomandibular joint disorder. Okay. So if you were never told that, if you were just like, oh, it's just some like congenital thing, or it's just people who have certain types of disorders that have this, like, please know that function does play a role as far as where everything is resting. Okay. How all that comes together is that it really does contribute. The oral myofunctional disorders are going to contribute to how all the muscles are functioning. Because when there's dysfunction in one part, so even if it's just how the tongue is not resting where it should, and then we have other muscles that come in and they are going to compensate in some way, shape, or form. Now we've got them doing functions that they shouldn't be doing, or collaborating in functions that they shouldn't be collaborating in, and it's going to create all sorts of functional chaos. Chaos is the best word I can come up with that. So an oral myofunctional disorder, for those of you who are not familiar, is an inability to utilize proper oral or facial muscle function. That's characterized by over or underutilization of the muscles, or compensatory utilization of the muscles when breathing, chewing, and or swallowing, or at rest. Okay. And good. I'm glad you guys are giving me the cues that everything is good. Just checking back and forth. All right. This is going to manifest as a number of things. It can manifest as a myriad of things. As a person who has 4 children who are genetically similar, I'll tell you that all 4 children manifested very differently their oral myofunctional disorders. They had similar diets, breastfed, or we had like similar relationships for all of the children, 3 that had very similar labors. Like it manifests into a myriad of things. It could look like a number of things. So here's a small, very petite list of some things that you might see in your patients. Tight musculature. That mentalis, I think, is the one that people like to point out the most. This muscle here on top of the chin, and they'll be like, oh, it's bunched, or it's dimpling, or you could see that it's just very prominent. That tight musculature people will identify with a quickness. But there's also tight musculature that you could just feel all throughout the mouth. And I think dental professionals and our tactile senses are above and beyond that of any other profession, because we're in the mouth so much, because when you go to retract, you can feel if somebody has a tight cheek, if their buccinator is really tight, you're feeling these masseters, you're like, what is going on with this person here? Like, are they in the gym, like weight training with just their cheeks? It's wild. You can feel the musculature. So tight musculature can literally be just about anywhere. but it's going to manifest in ways that you're going to be able to prominently distinguish clinically if you are in the dental field. Lip incompetence, which is a different soapbox that I'm standing on these days as far as the difference between lip incompetence and then just having like open mouth posture. There is a difference. Unilateral mastication, just chewing on one side and having a side preference. There are some people who have that for a reason because of occlusion or an inability to occlude on one side. So an open bite that they might have just unilaterally on one side, or they might have it on both sides. And so now they're improperly masticating in the anterior. And so instead of it being unilateral, it's just here and it's still identified as unilateral. Parafunctional habits. Can anybody tell me? And I love asking this when I do CE courses. So throw in the comments for me if you can. Can anybody tell me what is an example of a parafunctional habit? I'm going to move on to tongue thrust while I'm waiting for hearing about parafunctional habits, because there are dozens of parafunctional habits, and I find that most dental professionals can identify maybe two, which we need to work on as a profession, because parafunctional habits are a myriad of things. Tongue thrust. Tongue thrust is what everybody associates oral myofunctional therapy with, and we are not just tongue thrust. Tongue thrust is not even in and of itself just a thing. It's more of like a manifestation of an oral myofunctional disorder. So that's going to be when you're seeing that tongue inappropriately pushing forward through the teeth or against the teeth when it's doing certain functions, whether it's in speech or swallowing or at rest or whatever. That tongue is inappropriately moving in a way that we don't want it to. TMJ dysfunction. That's what we're all here for tonight. That's one of the manifestations as well. I am not seeing any parafunctional habits in the comments. This is very sad, highly disappointing. Parafunctional habits, nail biting is a parafunctional habit. A lot of people tend to just jump right to bruxism. They'll say clenching, grinding. That's a parafunctional habit. Awesome. Like mouth breathing is a parafunctional habit. Excessive gum chewing is a parafunctional habit. Unilateral mastication is a parafunctional habit. Cheek biting is a parafunctional habit. There's a number of parafunctional habits. Any non-nutritive, maladaptive, adverse oral habit is a parafunctional habit. Like whether you have thumb sucking, like that counts too. There's a number of them. So let's go on to some of the health impacts of it. This is now going to manifest as a number of things. It can go down a nice, very deep, dark rabbit hole in psychological disorders. I think is one of the things I like to talk about more recently. One of my very previous passions and still close to my heart is periodontal disease and the impacts of oral myofunctional disorders on periodontal disease. But oral facial pain is what we're going to get into tonight. Okay. So I'm going to pray that these videos work out well. Let me know if you can hear the video see the video, I should say, because you're not going to hear this one. This one has no sound. I'm going to talk over it because we are going to look at the muscles of the temporomandibular joint. So we've got our temporalis, we've got our masseters, we have, as we're spinning around here, it's going to stop and it's going to get closer in, and we'll get to see the digastric, the posterior belly of the digastric muscle. Stylohyoid. This is your disc, your articular disc. You're going to see the lateral pterygoid, the medial pterygoid. This is the medial right there. And as you look from the back, I think it's really important to see how all the muscles kind of work together. So we're groups of muscles that help to elevate the mandible and depress it. So medial pterygoid very much involved in depression, lateral pterygoid involved in elevation. The masseter, along with the temporalis, is involved in elevation, protraction, and how we masticate or have our rotary chew. So all of the muscles kind of come together. So when there's dysfunction among one, and more often than not, there's going to be dysfunction among others. Okay. Hopefully everybody was able to see that. I am. Oh, thanks, Marie. Hair chewing. Yes, that is one. Blanket sucking, tongue sucking. Yes, these are all parafunctional habits. I'm so happy that there's somebody else who's identifying parafunctional habits. These are the jam. Okay. So now, if I can get past this video now, there we go. Myofunctional therapy, what role does it play with temporomandibular joint disorder? Myofunctional therapy does actually not work in all instances of temporomandibular joint disorder. If you were not aware of that, then this is a really great time to talk about it, because I think when a lot of people hear TMD, they immediately want to say, okay, I know who you can go to, oral facial pain specialist or a myofunctional therapist. No, it's not all cases that myofunctional therapy can help. In a lot of instances, I really want to know that there has been some sort of scan, a CBCT, or some sort of functional evaluation done to determine whether this is a structural problem. So, has there been any wear on the joint? Is it starting to deteriorate over time? Is there arthritis involved? Like, what is happening with the joint itself? If the joint itself looks good, it's just not functioning well. If it's muscular in nature, that you're having the temporomandibular joint dysfunction. Awesome. Myofunctional therapy is perfect there. There is ICR, idiopathic condylar resorption. That's a big thing that happens where open bites are often confused, and it's a lot of time in adolescence. So from like 13 to 17 or 19 or something like that. You'll see it very commonly and prominently, more so in girls than in boys, but that's not to say that it doesn't happen in other ages and in other instances. But you'll see the condyle will start to have some idiopathic, it just happens, resorption. And these are surgical cases. Like, these are cases that require collaborative treatment in a different mechanism and manner in order to address what's going on. Arthritis and arthritic conditions, where it's not a myofunctional thing, it's not a functional thing. We have to deal with a deeper cause. Structural alterations or trauma. So a lot of times car accidents and incidents where people are in a like head on or a rear end thing, or sometimes where they're hit directly by some sort of object, or they bang their head or something in the car. You're going to find that there's some sort of trauma that will happen there, and it's not muscular in nature. There will be some level of collaborative treatment in most trauma cases. However, myofunctional therapy is probably not your primary first place to go when you're dealing with that kind of stuff. So if there is this displacement, surprise, because I think a lot of people don't think about myofunctional therapy when there's this displacement. You're like, oh no, you need like an orthotic, you need like this, you need that. That's not to say you don't need that stuff. You absolutely do need that stuff. However, in addition, myofunctional therapy can help to address that disc displacement as well, and muscular tension, and help to deal with that. Okay, awesome, fantastic. All right, let's talk about how myofunctional therapy helps when it comes to a reverse, perverse, or tongue thrust swallow, because it's called a number of things. Hopefully you'll be able to hear this. Let me know if you can't.
The reverse swallow starts with the lips open and much activity from the lower lip and mentalis area. The teeth are not together and usually separated by the tongue. The mandible is moved backwards during the reverse swallow.
Very important.
The tongue tip moves down and forward between the teeth. The tongue body moves down and away from the maxilla. Note the backward movement of the mandible.
Very terrible. That retrusive action of the mandible.
The action of the tongue distorts the upper arch. The tongue moves between the anterior teeth, causing lower crowding and class 2 malocclusion. The TM joint is compressed as the condyle is moved back during each and every swallow.
That was the important part, okay? That was the important part. So if you caught nothing else, that you're able to, compress against the temporomandibular joint every single time you're swallowing. It's a lot. I love this paper. This paper really put together the OMT part of temporomandibular joint disorders and how we are in team, it puts it together so beautifully that oral myofunctional therapy aims at an equilibrium of the functions according to the occlusal conditions and to the condition of the joint itself. So the subjects who followed the therapy in this particular paper learn to control their movements and avoid joint clicking and pain without negative compensations. And they start to recognize the factors triggering the symptoms and to avoid or control them as everything is really explained. So it's a lot of education in order to get that cognitive awareness of what's happening and where all of the dysfunction is happening. But then as you are retraining muscles and you're learning about the dysfunction and you're, working on jaw grading and you're working on how the joint is riding in in the socket, how the disc is riding, how everything is moving together, you're really starting to put the pieces together that when you see it happening inappropriately or feel it happening inappropriately because you get a heightened sense of sensory perception and awareness, you are at that point in time, boom, much more capable of being able to control it when you are, a little more subconsciously engaging in these actions. So once we have done the peristaltic oral phase swallow, it looks a lot different than the perverse reverse or tongue thrust swallow that we saw in the video previously.
The normal swallow is not spectacular
at all.
The lips are together at rest with minimal activity.
He meant no activity.
The mandible moves slightly upwards as the teeth contact. The tongue tip moves up against the premaxilla, followed by the body of the tongue pushing against the maxilla.
That's that peristaltic wavelength.
This creates the correct arch form and good dental alignment. There is minimal compression of the TM joint.
So now we're not compressing the joint at all, which is awesome. It's absolutely fantastic. That's what we want when we are doing these things. We want to have minimal compression. Okay. So I'm going to start this so that you could see what's going on. But with our myofunctional therapy, oral myofunctional therapy, we are doing a number of things. One of them is going to be dealing with disc displacement in cases of disc displacement by helping to facilitate the creation of a pseudodisc. Now, this is not intentional. This is something that would happen probably anyway, but it's also going to limit the ability for the patient to now have that same displacement thing again as they are in translation with their jaw, okay? I know there's a lot happening here. I'm going to start this at about 35 seconds.
The temporomandibular joint, the tubular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
Scar tissue working to our advantage in order to help the patients be less symptomatic. So if you've heard of somebody doing myofunctional therapy and they were locked previously, I've had PT clients. I don't know why I always get the physical therapists who have temporomandibular joint disorder who come to me specifically to deal with that, because while they have a lot of the manual manipulation, and it's neither here nor there because it's very controversial as to some of the manual manipulations and releases and whether or not you're actually reaching the muscles in certain parts. But when it comes to their manual releases, you can only get but so far. They have to deal with the function. They're not stopping the clicking and the popping because the disc is displaced, because now they have to really build up that scar tissue and learn how to really ride on the joint appropriately so that they can function the way that they would like to. So I always wind up with these people, and I don't know how I wind up with them, but that's the real area where you're winning there. And that's where I thought that video explained it so beautifully, because in the conversations I've had with these PTs, and PTs are like the kings and the queens of anatomy, that is like the joint conclusion and that we have come to is that we have to work together and collaboratively with other professionals. So manual therapists, structural like providers who are going to do orthotics or do appliances or orthodontics. That way they can help to facilitate the structure, but the function has to come along with it so that they can get out of all of the pain, the discomfort, and avoid ever having to do anything other than facilitate the creation of a pseudo disc and then stop that clicking, that popping, and stop the orofacial pain there as well. Okay. So when there is disc displacement, so when you're getting those patients who click, who pop, ask them about the head and neck, neck and shoulder tension, because oftentimes you'll find very much conjoined is going to be temporomandibular joint disorder and tightness in that sternocleidomastoid, the traps, the masseters. Like they're going to feel tight and tense, and then you'll be like, oh, I have so much tension, or I can only turn like this much, or I can only do this, or I can only do that. Like I can't do much more, because they're just kind of locked in all throughout when they have the disc displacement. And so you want to do some of that manual therapy. You definitely want to do some exercises and range of motion and start to deal with that as well too. But it all goes together with the oral myofunctional therapy, because here's the kicker here, okay? So when we're talking about temporomandibular joint disorder, the very true cause in muscular cases of problems is the retraction of the mandible, okay? And that jams it back into the glenoid fossa, also known as the socket. So it's jammed back time and time again, and then that's popping our disc out of where we want it to be. And now we've got disc displacement, right? So now we've got issues with temporomandibular joint disorder, the clicking, the popping, the deviation and disarticulation and so forth of the joint. So when there's an underdevelopment of the maxilla, so the maxilla is not adequately forward. So we've got mid-face deficiency. When there's improper tongue posture, when there's mouth breathing, all of that are going to really bring back that mandible. That's excessive retraction of the mandible. Now you add on to that dysfunction, such as a tongue thrust or a perverse swallow, or, now that's also jamming it back every single time too. So you're already retracted or protruded, and now it's going back even more. All of that is going to jam it into the fossa. And as it's being jammed into the fossa and it's hitting and it's hitting and it's hitting, that is deteriorating your socket over time. So the socket's deteriorating. Part of the bone on that condyle is starting to break down too. Sometimes you'll find that on the CBCT. So you'll have structural disrepair is what I wanted to say, but you'll have evidence of structural issues as well as that disc displacement where the disc is not where it's supposed to be. And you're going to need to help your patients create a pseudo disc and really establish just proper motion of that jaw bone, that jaw joint. Okay, so hopefully that all made sense. Let me know if I'm losing any of you anywhere. Happy to, help out if I've lost you somewhere. Okay. Do I have another anatomy video? I didn't even realize that I had two. Here's another one. I don't even know what's on this one because I thought this slide was hidden.
Airway and TMJ.
Oh, this is perfect.
The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly, mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward.
Same
Upon
thing.
opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur.
Locking.
A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backwards. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
Awesome. Okay, so I'm glad that I had that in there because I completely forgot about that whole video whatsoever. It puts together, one, the retraction, two, the impact of malocclusion, the impact of the forces of such, why There is parafunctional habits happening, how the disc displacement happening, like all of how airway and TMJ come together, but in a way that I think makes a lot more sense than sometimes some of my rambling, because I tend to like get all over the place. Who explains this significantly well? Dr. Dania Tabimi. Dr. Tamimi is the author of this fantastic book. It's got such great pictures about CBCT and imaging and temporomandibular joint and all the types of dysfunction. And I'll tell you, as a person who's sat in on 2 of her lectures so far, phenomenal. If you see anything by her, and I know there's a course that is being promoted on Facebook because it pops up on my feed all the time. If you see anything by her, please take it, because you have no idea what you're looking at when you look at a CBCT. You have no idea the inaccuracies of like all the different things that we keep claiming are, dysfunctional airways or good airways or whatever. Like a lot of the soft tissue stuff on CBCTs is very subjective, highly subjective. But the hard structures, like the temporomandibular joint, the things that we can see and the breakdown of those structures and how the teeth are and the position of the condyle and where the mandible is versus the maxilla and where it's retrusive, like how we can see and read that to indicate to us the health of what's probably going on with the muscles around these structures, that is the real gold. Okay. So Dr. Tamimi, phenomenal, absolutely phenomenal. This book, really great read, or just a great visual flip through, but to understand it really, really deeply beyond what that video was able to really convey, I think it's incredibly important in understanding how OMT and TMJ disorders go together. Okay. All right. So you're going to need a splint if you're dealing with any sort of person who's having a dysfunctional joint. Here's why: because you have to protect from all of those forces and you have to kind of level out the occlusion. So you'll have some patients who are in extreme pain. You'll have people who get locked multiple times a week. I've had those patients multiple times a week. They're getting their jaw locked. They're struggling when they wake up in the morning. It's tension headache after tension headache. It is this, that, and the next. It just compiles and compounds and continues again and again and again. And it's very destructive to a lot of our patients on their teeth and the structures of the joint itself. So you saw how it can really like wear down on the joint. All of that is going to impact your progress as an oral myofunctional therapist. And so you will not be able to adequately get through some of the temporomandibular joint stuff if you don't stabilize first. So when there is a fire, there is no point in calling a contractor to say, hey, how can we rebuild this house? Should we put out the fire first, maybe? And then we can worry about how we're going to rebuild the house that's on fire. Like, let's put the fire out. So you got to put that fire out first. You got to protect from the dysfunctional forces, get them to a new set of occlusion, because it's really going to offset their occlusion to a way that's a bit more harmonious for the joint, so that we could stop the dysfunctional breakdown of the joint itself. So you're still going to work with people who do splints. You're still going to work with orthodontists. You're still going to work with people who are specialists in temporomandibular joint disorder to help protect from the dysfunctional forces, get them to a level of stability. They're going to put out the fire. That way you could say, okay, hey, I'm the contractor. I'm going to tell you how we're going to rebuild this house. Here we are. Our muscles are stable here, relatively so, for where they can be when there is dysfunction and compensatory patterns. But here in my oral myofunctional evaluation, here is where I see that we need to rebuild. These are the muscles we're going to work on. This is how we're going to help the jaw and be able to ride on it better. Okay. So now that we've dealt with the fact that you do still need splints, you still need all of that stuff, where does myofunctional therapy come in? It's to habituate the functional forces. So you really want to now be able to say, okay, here's how function's supposed to work. Here's how we're going to work on grading the jaw upon depression. Here's how we're going to work on grading the jaw upon elevation. Here's how we're going to work on chewing and rotary things. I think it's a lot of times Before stability, you want to tell your patients to avoid chewing and those types of things. But once they're stable, myofunctional therapy actually comes in really well, exceptionally well, because you would think that the chewing, I have a temporomandibular joint disorder, chewing and tension, it's going to be bad, right? No, they actually need more of that, but they need it in a functional way and with a functional pattern. So it's really about the good balance of having all of that being habituated to new proper patterns and so forth. In addition to the fact that as oral myofunctional therapists, we are going to help improve the tongue posture. So now there's stability between the internal soft tissue forces of the tongue versus the external soft tissue forces of the lips and the cheeks. And all of that is really going to balance out and help us to provide some stability. We're going to eliminate the mouth breathing. You saw the video with the TMJ. Like, we're not going to be creating these retractive patterns of the mandible again and again and again and continue to break it down. We're going to start working on function. So we're improving all of the muscle function. We're working on function, and we're starting to help create that pseudo disc. And then we're always on the cheerleading squad for so many other people, which is why I think people really love working with myofunctional therapists. If you don't have a great team yet, you will have a great team who will highly believe in you, because you will work like a really great circle or network where they're sending people to you, you're sending people to them, and everything is moving because you're all encouraging the patient to see all of the people. So yes, you still need the manual therapist. You still need the physical therapist. The physical therapists need a myofunctional therapist. Like, I know firsthand they need a myofunctional therapist. So the physical therapists need a myofunctional therapist. The myofunctional therapist needs the physical therapist. All of those functional providers, be it PT or MFT or OMT or whatever you want to call us, we need the structural providers. So the structural providers are your functional orthodontics, your orthotic providers, the people who are going to help with the occlusion. Not every case is going to be perfect. So I've been deep diving into a lot of things lately. And I will say that while I love my field, I feel like there are a good number of people who are blissfully blinded by the field. And here's what I mean. If you've ever been online and you've seen somebody passionate about something, right? Really passionate about bee stings. That's a thing. People are very passionate about it. You have Lyme disease, you need bee stings. Bee stings are going to be one of the only things that can help you. You need to have a live bee. You need to put it on you. It needs to sting you in a certain place, and that's going to help you with your healing and so forth. And like, it's the only thing that works. Nothing's worked. I've done this, and this for my Lyme disease, and nothing's worked. I've spent $40,000. It's the bee stings. We need more bees. And then you look at that person and you're like, wow, that sounds pretty wild and like out there. That's what we look like to other people when we start talking about like myofunctional therapy and airway being the answer to all things. It's not the answer to all things. Not everybody ends up in like beautiful, perfect occlusion. Some people end up in occlusion that works for them. Some people have malocclusion and don't have any dysfunction. Shocker, right? The rules don't apply to everybody for everything. Okay. So when you're working with a structural provider, I find it best to let them lead as long as you are, collaboratively working together, because some people are going to be done with an open bite. Some people are going to be done with certain things out of place. And then over time, between work with, a prosthodontist or a cosmetic dentist, they're going to work on these things by building stuff up or breaking stuff down and yada, yada. As long as you're habituating your function and you're doing your role and you've got your manual therapist in there loosening up all the tension, you're going to be better off in the long run. Let me just check real quick. Any comments? No. Good. Because, anytime I say something that might be controversial, I like to check first and make sure there are no comments that are going to be like, what are you doing? What are you saying? Okay. So those are our goals. That's our role. We have to work with other people. Not all patients are going to be the same, or clients are going to be the same and end out with wonderful, beautiful occlusion. And sometimes you're not going to clear all of the deviations, deflections, you're not going to be able to do all of it. And so working collaboratively, you can get them to their functional best. Yay. So I think this is the wonderful point in time where you're like, well, what do I do with this information? Are you going to give me some exercises, curious? Like, how am I supposed to figure out what I do now with this information? Well, I don't know exactly who I'm talking to. I'm talking out into like the internet. I'm just talking out into space. So I have no idea who I'm talking to. I don't know what your level of knowledge is in oral myofunctional therapy. I don't know if you're a dental provider, if you're a medical provider, if you're whatever. So I'm not just going to throw out exercises at you. That would be irresponsible, because then you would then go out and start giving your patients these exercises. And we don't know what everybody needs, because unless you're really good at doing comprehensive oral muscular functional evaluations, you have no idea what they need, right? So what do you do with this information? You keep doing what it is you already do. Like, so tell me, what is it that you do now when you have a patient that has, temporomandibular joint dysfunction or disorder? What is it that you do? A lot of people will give them massages and massage techniques. And these are also, I'm not going to downplay the necessity of all that stuff. We actually need everything. Okay. So we need the massages, we need the manual releases. We need you to keep doing those things. If you know those things, please continue to do those recommendations. If you're going to tell them to avoid chewing, they need to go see a specialist for an orthotic, please continue to do that. If you're going to tell them that there are some minor exercises, or some resistance exercises, whatever. If you feel comfortable doing that, do that. Okay. You keep doing that. If that's what you've been doing and it's been working for you and it's working for the people, the clientele, the patients that you work with, then please continue to do that. If you're telling them to alternate hot and cold, alternating hot and cold is a time-tested, again and again, proven method that works for a lot of people. So do that. Please continue to keep telling people that. If you're telling them to take anti-inflammatory medications, please, if they're taking something over the counter, continue to tell them to do that. So whatever it is you're doing in whatever capacity, I want you to keep doing that. But know that myofunctional therapy is a great adjunctive that can help. I also want to take a minute to say that what you think physical therapists know or are familiar with, even in some of their advanced physical therapy things, is more about the muscles, how the muscles work, releases and manual releases of such, some light exercises specific to that. But it's not going to address the full scope of what's going on with the dysfunction. So that's why we get the PTs who are like completely lost with why they're not getting any progression, why people are not being able to sustain or hold the releases and the change that they're getting, because there's so much more function that needs to be habituated. There's so much more to the tongue posture and the intraoral versus extraoral tongue pressures. There's so much more to the overdevelopment of certain muscles and the underdevelopment of others, and the recruitment of things in inappropriate tasks. There's so much more than just some isometric, dealings with what's going on around the joint itself and the limited number of muscles. Limited, I say limited as if there's not like 6 different muscles that have to work together in order for us to facilitate chewing properly. But this is something that is collaborative. So you want to continue to do what you're doing, but also know that myofunctional therapy is actually a phenomenal way for you to be able to sustain long-term results for your patients, because you're going to be giving them the beautiful power of a pseudodisc and knowledge of how to avoid being in this again. Okay, how to avoid that at all. Okay, I'm pretty sure this is my last slide. I'm going to go back to my other screen, and no questions as of yet. If you have questions, pop them in the chat. I do want to say that I wanted to take a moment out to say, like, okay, I know one of the questions is going to be, what does a myofunctional therapist do What kind of exercises do they do? What kind of muscles do you work with? We work with all of them. Okay. We work with all of them. I do not limit myself to, oh, you have temporomandibular joint disorder. Okay. I'm going to see you for 5 visits. And during those 5 visits, we're going to do like 20 exercises. And that's going to be the end all be all for you. No, you need a full program, because to habituate your dysfunction into proper function, it's going to take an undefined amount of time. Undefined. I want to introduce you guys to the MandiTrack. If you are not familiar with the MandiTrack is like its own type of orthotic. I use it for all of my TMJ patients, especially, and the PTs love this a lot, and they tend to work with it a lot. I have some OTs who love this too. And essentially what you're going to do with this is 3 different types of exercises. So they have one exercise that works specifically for the masseters, where you're chewing on the MandiTrack appliance. You're going to place the rollers. So it's got these 2 rollers, which are, if you ask me in the simplest terms, this is genius because it's putting on a handle are the aligner tray seaters. That's what these are. It's putting on a handle our aligner tray seaters, and then you could have the aligner tray seaters be stable as opposed to just using them without stability. I do still use them without stability. I do still use the MandiTrack as, like, you know, I use it in multiple ways. But here is one of the exercises for the masseters with the MandiTrack, which is sold by Dynaflex now. It was created by Cindy. I know her last name. Oh, she's going to kill me if she sees this. It'll come to me. Cindy, phenomenal, absolutely genius. She's such an amazing person. If you ever get to know her, and I will think of her last name, I promise you it's on the tip of my tongue. She sold it to Dynaflex. So Dynaflex is where you can get these. It is a phenomenal, wonderful thing that you can buy as any type of provider. You don't have to be a dentist to have an account with Dynaflex to purchase one of these, okay? Now, here we are. We're going to take the 2 rollers against the molars. Chewing. "30 seconds. Then you're going to move it up to the premolars. So just behind the canine. For those of you who are not familiar with where your premolars are, your canines, between your canines and your molars are your premolars. Push it in the premolar area, and then you're going to roll. So you're working your pterygoids now, medial and lateral, as you excurge. That's not the right word, but as you protrude the mandible and retract it. So you're going to push out and roll back and forward. For your clickers and your poppers, slow it down. Don't have them rapidly moving. Again, you also don't want them rapidly moving for the chew. Don't rapidly move for anything. It's not about doing it fast. It's about doing it well. And so you want to take time to be conscious and intentional with how you are riding on the joint. And that's really like the beauty of this thing, is that you can really sit there and process it without having to worry, is something going to slip or fall. Then we're going to take a 45-degree angle, and we're going to still be in that same area with the premolars, and we're going to continue to roll at a 45-degree angle, and it helps to work the genioglossus, which is that essential muscle when you are trying to keep that tongue up and out of the airway. The genioglossus, in combination with other muscles, because I hope everybody knows that their tongue is a muscular hydrostat, okay? The tongue is going to stay up and out of the airway primarily with the genioglossus in mind. And so we're going to get that 45-degree angle of the chin, premolar area. You can do this in a number of ways. I love the MandiTrack because it's easy. It just puts it right in the patient's hand. The patient's able to hold it. They can stabilize themselves. They can go slow. They can really like do it with you. And so I prefer that. But when I have lesser dysfunction at the temporomandibular joint, or there's just different ways that I need this to be done, I'll take aligner tray seaters, and we can always just put them on and use them how we need to. to chew, or a wafer disc. And so the wafer you can slide forward as well. And so sometimes I'll use that even with children to get them sliding to work on the genioglossus with the 45-degree angle with a wafer disc. I know I definitely said that I wasn't going to give you guys exercises, but I think the MantraX is a phenomenal device. I think there's a number of great exercises and things and a lot more that I do when it comes to TMD, but these were just a few. If you find that you've been doing along with me and with this video some of the work and you need to relieve some pressure off your temporomandibular joint and you want to just help that joint really briefly, I love this exercise that I call monkey mouth. I know other people have a different exercise that they have monkey mouth, but whatever. I think of Boots the monkey when I do this because you're filling up your whole mouth with air, and that's really like Boots from Dora the Explorer. It's like Boots, he's really full down here and like not as full up here. So you're filling up your whole mouth with air. Nasal breathing. Don't hold your breath, but filling up your whole mouth with air and holding that for 15 to 20 seconds and then relax and let it go. That's going to help you to relieve a little bit of the tension there from the joint itself. As you're working on a little bit of nasal breathing too, because, you know, clearly I don't want you holding your breath doing that. I don't see any questions in the chat. I would love to welcome any of you to ask any questions. I will say that I just got to go through the Myo community. If you are not on the Myo community on Facebook, please do join the Myo community on Facebook. It is a wonderful place with a lot of great resources. At this point, nearly 25 hours of like these types of lectures and things where you can learn more for free. I'm not charging anything. It's a Facebook group. Like, I'm here giving you my time just because I love you. So, you know, I joined the Myo community, but I don't remember what I was talking about the Myo community for, but join the Myo community. Oh, I got to start to look through some of the things that people, because everybody, if you're going to join the group, it's going to ask you 3 questions. One of the questions is going to be, you know, what is it that you would like to learn more about and whatever. And the most popular answer, because I just started looking through them, was TMD. So if you have something that you would like to learn and to know, pop it in the comments or, you know, send me a message. I'm happy to create a whole lecture on it and to really explain it out for you. You just got to let me know that that's something that you want and that you're looking for. And then let's talk about it. Like, let's get in there. I will also say that Vita is phenomenal. Vita from Myo La Vida is phenomenal with TMJ, and she has a lot of great resources and is a lot better at talking about it than I am. I talk about it from my limited understanding of it, but she's actually like super duper wonderful. And so that's another great resource for temporomandibular joint disorder. But I think I've rambled enough for everyone and their evening. I am so happy to have been here with you. Thank you for watching. And I look forward to seeing you next week where we'll talk about something else myo related and awesome. Have a great evening, everyone. Bye.